balance. And specifically, we're doing with hormones and endocrinology. Okay, so it's like the never-ending quest for that homeostasis. And the big important thing with that is if you understand what normal is, then it's going to help you recognize diseases and what to do with the diseases, what labs, all of that. So a lot of times when I teach, I lean back on what happens normally to help identify what to do next, okay? Endocrinology is not the same as ortho. We're like, ortho, they can be like, I hurt right here. Oh, okay, it's probably, I don't know, lateral epicondylitis, right, overuse. Endo, they come in with fatigue. They come in with weight gain. They come in with menstrual cycle changes, right? So it's a cluster of signs and symptoms, a cluster of physical exam findings. We use that to get to labs, RADs, and that sort of thing to get to the diagnosis. Luckily for endo, there's really not very many RADs that you order. It's typically an MRI of the brain or maybe CT. But the labs get a little dicey, so I'll help you pay attention to what's important. 10% of patients take up 90% of your time. Any thoughts on that? It's like the person who comes in with fatigue. Is that person where you have basically you go through your day and cruise, but then sometimes you just have that one patient that is a puzzle. And if it's endo related, after taking this course and stuff, you'll be able to figure it out. Okay, block 1. So again, we're going to do the intro and post-pituitary today. After every lecture, there will end with the clinical cases. So as a group, we'll present a patient, sheet complaint, and we'll go through a scenario. The point with that is to just solidify the information we just talked about and then apply clinical relevance, right? So what are you guys about? Yay, right in clinic. So at the beginning of each lecture, we'll do a check on learning, so multiple choice questions, just to get you kind of in that mode too. For what? For the test and for the pants, okay? There's also time for a review, a quick review that we'll do before each test, and then a lab. And we'll talk more about the labs as we go. A lot of the topics we're going to talk about, this is the first time you've been exposed to them, at least at this level, and into the diseases. So I have recommendations on how to be successful. It's gonna maybe make me sound old. It sounds really simplified, but I just suggest you pay attention during class. Because if you wait until the weekend before the test or the week before the test and you try to digest all of this, especially for exam 1, it'll be a struggle. Because when it comes to the test, the hormones get confusing, the feedback loops can get confusing. So just if you get exposure in class and you kind of have an idea of like, oh, this is making sense, or I don't get this, I'm gonna listen to it on the way home, okay? So does that make sense? So just, I recommend being present. Now you're all our juniors, some of you are adults. By now you have your study system, right? Some of you pay attention, others are studying for the test that's coming up, right? Can't control that, but just my recommendation, or at least for your success, because I'll be here regardless. Questions on the breakdown? No subclinical cases. So in clinic, you will have subclinical cases. What does that mean? Yeah, it's not like classic, right? So their labs won't be classic, their symptoms won't be classic. So I won't do that to you on a test. Okay? I mention it from time to time because like subclinical hypothyroidism is so common that I had to create a slide for that, but I'm not going to test you on it. Okay? Most of the time I'll give you normal labs. You'll know when I won't, and it's not for this one, okay? And then obviously understand medical abbreviation. Endocrine was 7% of the PANCE, but when they redid the blueprint, it dropped down to 6%, but the actual topics expanded. So roughly 21 questions on the PANCE will be endo, and here's those topics. And then obviously I correlated the lessons that I teach with each of those topics. And gastroenterology, so obesity, we talk about because it ties really well into diabetes, and a lot of other endocrine discussions that we'll talk about. Any questions so far? All right, let's do a question together. First order question. Okay, I do have a handful of those. Do you guys know, does the PANCE ask first order questions? What do you think?
No.
Yeah, they don't. But they do in a way, but they're always going to have a clinical vignette. So it'll always be like a 26-year-old female with, but it might be shorter and it might be asking a very like first order question, but it's going to be long. But I do give you a few in junior semester, so let's do this one together. Which of the following hormones is secreted by the adrenal cortex? C. Okay. Perfect. Thank you for participating, because even if you guys should feel safe. You've been with each other for 3 semesters. Feel okay getting anything wrong. We learn from our mistakes. You guys got it right. Okay. Let's take it a step further. And we have a 32-year-old male complains of a 40-pound weight gain, symmetrical joint pain, increased fatigue over the last 3 years. His boot size has changed by 2 sizes during this period. On physical exam, he's hypertensive. His weight's increased, which you confirm by vitals. And you note an enlarged forehead, palmar hyperhidrosis. What's that? What's hyperhidrosis? Yes, that. And, sorry, I'll repeat, excess sweating. And what about progampism? So that's like the forehead will stick out. So it's like a pronounced forehead, okay? Which one of the following is the most likely diagnosis?
C.
C. I have an A. Okay, good. So this is kind of the breakdown just for if you're studying and how you can break down this question. Do you see how in endo especially, I can't just say this patient has fatigue. I can't just say they have fatigue and hypertension. I have to paint the picture. So I promise I will do that. The pants will do that. I'm going to paint a picture to get you towards the right answer, which is acronym. Okay. We'll learn not tomorrow, next week why it's not A. Okay, so this is a third order question, the exact same scenario, but the question changed in green. Which one of the following is the best initial laboratory test to order for this suspected condition? So we know it's acromegaly. This is probably the hardest one. And we'll talk about it tomorrow, or I keep saying tomorrow. We got morning cortisol, growth hormone, prolactin, testosterone, or insulin-like growth factor. Here, B. Anything else?
B or E.
B or E? Okay. I like it. So in this person, the issue is growth hormone, but we're going to learn next time how that growth hormone lab specs. And so instead of using growth hormone, we have to use insulin-like growth hormone factor. I don't know.
Dual credit.
So, good job. This slide just again reiterates that it's a cluster of symptoms, right? Somebody doesn't come in and say, hey, I think I have a prolactinoma. No, they're going to come in with erectile dysfunction, visual changes, headache, right? Maybe gynecomastia, so breast tissue. Same with the physical exam findings, right? You have to actually do the physical, so we want to lift the picture, see if they have purple stretch marks called striae, right? We want to do a thyroid exam, right? Was there any nodules? We wanted to check for any hyperpigmentation, so things like that. So I'm going to give you physical exam cues, but just again know it's a cluster of things. Like a nice mystery or puzzle to solve. But I promise I'll only give classic, and then we don't cover those things anymore. Turners and German over there in this class. So I added this because this overlaps with ClinCore. We're finally lacking ClinCore after weeks not meeting. But in ClinCore, I tell my groups this, and I said the same thing in phase 2 with OSCEs. If you get a good medical history and do a solid physical exam, the OSCE, the answer is there. Even if they have chest pain or shortness of breath, good history, physical exam tells you it. And the same thing with endo, right? The history and physical exam paint the picture. The hard part is then we have to use our medical knowledge to see what labs do I want, what rads do I want. Crap, I have to treat this patient. And I have to educate them, so we'll build on that in this class. And then obviously listen is bolded, but that's more for phase 2. Okay, jumping into these objectives. So, endocrine system, all regulated by hormones, okay? It's a collection of cells and glands that produce and release these hormones. And it's important, right? We can't grow, cellular growth depends on our endocrine hormones. Sexual development, right? Reproduction is huge, right? All of these things. Water and electrolyte balance is going to be what we're going to talk about next. A lot of people don't think about that. Also our stress response, fight or flight. We think with like nervous system, but it's also correlated in endo. So very, very important, and it regulates all the things. Okay? So I'm pretty sure they taught this way when I was in school. But there's overlap. You guys had neurology, right? You're almost done with neurology. So in neurology, how things are, they're, instead of hormones, they're using neurotransmitters, right? And neurotransmitters are released in the synapse. And things happen really fast, right? The heart goes to the muscle, the tissue, and you have a really fast reaction. Endo, instead of neurotransmitters, it's hormones. Hormones are released in the blood. They go through the bloodstream to their target organ, which is typically not close to the brain. So if it's the adrenals, it goes, the hormones released from the brain to the adrenals, where they do, they either, that's their target action, or they're converted and do a different hormone, and then complete their action. But it's much slower, and it takes over several days, okay? But there's a little bit overlap on how it communicates. But again, it's all through hormone release through the blood supply to the target. You guys know this already for pathology, right? Hormones can be secreted free or bound. And it's that free form that's active. This, I'm not going to test you on this, but this comes into play when we talk about labs. So again, these foundations you learned in freshman and sophomore year, now we're going to use them for clinical medicine. All right, so we have two types of hormone classes. I'm going to go through this slide because I need you to understand it, but I'm going to teach you how you don't have to memorize all the examples. Okay, so again, this is my last, maybe second to last, and one more pathy related slide. So we have our lipid soluble. These ones are large. They're too large, they can't pass through the cell membrane, right? So they interact with the receptors outside of the cell that say, hey, let me in. And then they bind with that receptors, and then you have a cascade of events, right? And then the hormone is able to initiate its action. And those are your polypeptides and proteins. On the opposite, you have steroids and thyroids. These are small and lipid soluble, so they can go straight into the cell and go straight to the nucleus to institute the change that's needed. But they need to be chaperoned, right? So they're bound to another hormone to get to where they need to go. This information is helpful when we learn about labs. And examples of this, we look at the bottom. One thing you could do is you can memorize all the polypeptide proteins, but that seems silly because look, the names, steroids and thyroids. What's testosterone, steroid, progesterone, cortisol, aldosterone. So if I asked you a question, you know, which one, if I was comparing, you see how it's easy? It's either a thyroid or a steroid, and then vitamin D is an outlier. But so thyronines are your thyroid hormones, and then testosterone. Okay, so you don't need to memorize the polypeptides. You just need to identify what's a steroid and a thyroid. So this is more fun. This is a negative feedback. This is the bread and butter in endocrinology, right? So high levels of circulating hormone. So let's pick thyroid hormone. If my thyroid hormone T4 and T3 are too high, the body needs homeostasis, so it's going to respond by lowering the circulating hormone that impacts hormone synthesis. So you can read this, but it's more fun to read this. So this should be a review. Okay, so we have, let's see, homeostasis is disrupted, right? So we have too much T4, too much T3. So the hypothalamus is triggered and say, hey, we need more thyroid hormone in the body. So the hypothalamus goes and says it releases thyroid releasing hormone. Tells you exactly what it's going to do, right? So it goes to the pituitary gland and says, hey, we need more thyroid hormone. Pituitary gland says, got it. It releases its hormone, TSH, into the bloodstream and goes to the target organ, the thyroid gland, right? And the thyroid gland is doing what it's told. And so TSH gets to the thyroid gland and say, hey, we need more thyroid. Those follicular cells start working and do what? Produce more T4 and T3. And then you have homeostasis is restored. Voila. Okay, so that's your negative feedback review. If for whatever reason when I talk about negative feedbacks, if it doesn't click, come see me, because you need to know this to help you be successful when we get to diseases, okay? Best way to do is teach it to somebody else. Positive feedback, super important, but we're not talking about endocrinology, okay? So this is going to be in women's health with oxytocin, and so it's an NA for this class. Super important, just for different things. This slide, you don't necessarily need to memorize it all, just know, so you have the negative feedback loop, but there's more the body is doing to help support and maintain homeostasis, specifically the receptor availability, okay? And so if there's excess hormone, so if we have too much T4 and T3, too much thyroid hormone, receptors are going to downregulate. They're going to pick up on homeostasis needs to be restored. So they're going to downregulate and decrease the availability of to the target tissue. Does that make sense? So again, receptors play a role. The only overall, you don't have to memorize this, but it's the whole body is working together to reach that happy homeostasis. Alterations in endocrine tissue functions. Again, so primary alteration, this one's related to hyperfunction. So excess thyroid hormone, excess cortisol, right? So hyperfunction, that makes sense. If I say the adrenals are producing excess cortisol, I think that's a primary or secondary hyperfunction? Adrenals. So the adrenals is the gland that produces cortisol. So they're the primary organ. Does that make sense? Do you guys catch that? So adrenals, primary organ that produces cortisol. And I say it's a hyperfunction. Let me read this. Okay. Secondary, when I say something there is secondary hyperfunction, the problem is in the pituitary. If I say it's a primary hyperfunction, then the problem is in the actual gland. So the adrenal glands or the thyroid gland, okay? So if I tell you Graves' disease is a hyperfunction of the thyroid disease, is Graves' disease, where the thyroid gland produces excess T4, is Graves' disease primary or secondary? Primary, right? Now, if I say this person has a tumor in their pituitary gland that's causing excess thyroid to be released, is that primary or secondary?
Secondary.
Secondary. So secondary is pituitary, or and primary is that actual primary gland that does the work. Sorry, I'm confusing everything. Ectopic, you guys know that, right? It's another source is producing excess hormone, right? Typically cancer, but not always. Okay. So outside of the endocrine loop, outside the pituitary gland, you can have ectopic sources of excess hormone release. Hypofunction is exactly the same. So if I say something is a primary hypofunction of the thyroid gland, where's the problem? The thyroid, right? And if it's some failure in the pituitary gland, like someone had surgery, and the pituitary gland is damaged, is that primary or secondary? Secondary. Look at that. And then resistance, we're going to talk about that. That means there's plenty of hormone in the bloodstream, but there's resistance of the target organ that it can't do its job. Well, there's only 2 examples that we'll talk about that. One more today. These are just terms, should be a review, but fair game, we use them a lot, so it's worth kind of the review. An adenoma, it's the benign enlargement of glandular cells. So we're going to talk about adenomas a lot next lecture. Typically benign. They can be malignant, and then we call them what? Neoplasm, right? Hyperplasia is just the benign enlargement of a gland. So if I say adrenal hyperplasia, what does that tell you? The adrenal glands are bilateral, they're just enlarged. Not an adenoma, not a cancer, it's just over the entire gland is enlarged. Atrophy is the opposite, right? Wasting away. Hypoplasia relates to congenital issues. We do talk about a few congenital stuff as well. Any questions on those terms? We'll be like giving you that added on that. That's it for lesson 1. What time do I start? 4:40. So, okay. So, I'm gonna need help. Remind me, what time do I'll stop at 1:10. We can go to the next group of slides. All right, posterior pituitary. There's only one lecture about the posterior pituitary, and then the anterior pituitary gets all the attention for some obvious reasons too. Luckily, we're only going to talk about 2 different overall diseases related to the posterior pituitary. But before we do that, let's talk about the anatomy, right? So the pituitary gland is split up into posterior and anterior. Anterior pituitary is a true gland, but posterior pituitary actually isn't. And it's pretty small, right? So we have our sella turcica, and that's where your pituitary gland is. Don't worry, I do not have anatomy questions on your test. Just a reminder, where our pituitary gland is. It's not very big, but it's super important. And so the posterior part, like I said, is not a true gland. It's actually just an extension of the hypothalamus nerves. And you'll see that in another picture. So the hormones that are released are oxytocin and ADH. But again, it's the hormones are created in the hypothalamus, right above the pituitary gland, and essentially stored in the posterior pituitary so that when they're needed, they're released into the bloodstream, right? And for ADH, it's going to be antidiuretic hormone, it's going to go to the kidneys. And for oxytocin, it might go to the uterine muscles or mammary stuff for lactation. The only thing we're going to talk about in endo is ADH, okay? Oxytocin, important, but that'll be for one to tell. This is probably my favorite picture because it really kind of shows how much bigger and more functioning the anterior pituitary gland is. And then again, that it's just the hypothalamus neurons just end in the end of the posterior pituitary. So they're stored and then released on demand. That's it for anatomy. Okay, real short and simple. So let's go on to function. So antidiuretic hormone, or ADH, there's also, it's called vasopressin a lot. The full name is arginine vasopressin. I just will consistently call it ADH for this class. But no, it has multiple names depending on the text that you use. And it activates 2 receptors. So ADH plays a role to our blood vessels as well as the water balance in the system. So have you guys talked about pressors and things like that in cards? So vasopressin or ADH is a very weak pressor. So it's only really initiated when they've lost like a significant amount of blood. So what kind of like clinical scenario would ADH be released?
Shock.
Shock, yeah. Hypovolemic shock, they've lost a lot of blood, we need to throw everything we have at it, we're gonna throw in some ADH. For this class though, all I care about is the V2 receptors, right? And so they're gonna go to the collecting ducts of the kidneys, and the whole point of this hormone is to retain water into the body. So antidiuretic, it's in the name, right? Diuretic means what? Pee out, or an anti-water drug, right? Or anti-urine drug. So we want to retain water in the body to reach what? What's the whole point of this hormone? Or this homeostasis, right? The body has a really tight control of serum, the serum concentration, it's called osmolality. So we want to keep that right where we want it, and we use ADH to help. Okay. So again, it helps by holds the water in. If I hold water into the body, what happens to my urine?
Concentrated.
Yeah, it's concentrated and it's less, right? So so our urine production is lower. So more ADH, holding that water in, and I'm peeing less. And it's severely constipated. Any questions on that? We'll talk about it a couple more times. So our nephron, who still knows the ins and outs of the nephron from like A and P? Yeah, no, me neither. This is not to you. But we're going to talk about the collecting duct. So the collecting duct is where ADH works. So the body signals that it needs more, the balance is off, and it needs more water in the serum. So it's going to release ADH from the posterior pituitary gland, and then it goes all the way down to the collecting duct. As ADH levels go up, these channels called aquaporins go up, and so these channels come in the collecting duct, and it allows water to go back into the body. Okay. So that's essentially what is happening. So more ADH, more aquaporins, which is the channels. We get water retained in the body, and urine is decreased. So there's, for those of you who like the pathophys, which I actually do, that hopefully makes sense. So you're not just memorizing it, you can kind of visualize it. Any questions on that? So the regulation of ADH is actually really specific. So that there's an increase in plasma osmolality, which I'll talk to you about in just a minute, by 1 to 2%, ADH is released. So it likes a really tight control, okay? And osmolality is made up of sodium, glucose, BUN, but primarily it's sodium. Sodium drives the osmolality, and it's just essentially it's the concentration of these in the blood, okay? So serum concentration of sodium is more than just sodium, so we call it osmolality, okay? So there's receptors in the hypothalamus that catch like, oh, we need, the blood's too concentrated, so I need to release ADH to pull in more water. Okay. There's also baroreceptors that are super important in the atria. Again, that has to do with more of the B1 receptors when we go into shock. So I'm not going to test you on that. So we know that serum osmolality drives ADH. When ADH is released, we know where it goes, right? It's the collecting ducts. We know what happens. Water gets retained, urine output decreases and concentrates. All of that stuff will be helpful when we look at labs, okay? So this just talks about what stimulates and what inhibits ADH, right? It goes back to that concentration of the serum solutes, right? The osmolality. So hyperosmolality, need more ADH. Obviously, if I'm in shock, I need more ADH. And then, of course, all those lovely medications. But who has done this farm? No? Almost. All of those lovely meds that you learned in farm can potentially impact this too. And then, obviously, the opposite, inhibition. Hypoosmolality, so if it's low or we don't need so much water, we're going to decrease ADH, blood pressure, and then alcohol. Why is alcohol? What does alcohol do?
Lots of stuff.
I can't hear. What does alcohol do? Yeah, it makes you pee, right? It's a diuretic. So it's going to inhibit the release of ADH. So less ADH, we're peeing more. Then what else happens? We get dehydrated, right? We don't drink enough water. Beer, wine tastes so good. Yeah. So anyways, we have an increased chance of dehydration with alcohol, even though we're peeing a lot. So do not memorize this, but this is the calculation to find osmolality. I will give it to you on a test. I will say it's hyper or hypo, or I will give you the normal range in the lab. Not something you have to memorize, but just know there's actually a calculation. This is a summary of what we've said. I don't care about the cardiac baroreceptors, the blood vessels, vasoconstriction. Super important, but again, I care more about the osmoreceptors, the serum sodium, and going to the collecting ducts impacting urine. Okay. Any questions? My hands are so cold. You guys okay? You're used to this. My office is this cold. It's cold, right? Okay, you're not. Okay, my office is this cold, but I don't know. Okay, Are you guys okay if I keep going for 15 more minutes?
Yes.
This is okay. This is usually where I would stop and do a water break. Okay. All right. Let's go. ADH hormone disorder. So like I said, there's two. Syndrome of inappropriate antidiuretic hormone, otherwise known as SIADH, and diabetes insipidus, or DI. So SIADH is too much ADH, right? It's in the name. Syndrome of inappropriate ADH hormones. We'll talk about that and DI today. When you're differentiating between this, say in real life or on a test question, you gotta know a little bit of information. So I'm gonna have to tell you, or you're gonna have to ask about the urine, right? Is there too much urine? Not enough urine? Are they super thirsty? Polydipsia, right? What's polydipsia? Thirst, yeah. So if I'm peeing a lot, I'm always going to ask about their thirst. Are you polydipsia, right? Then I'm going to look at the labs, specifically the sodium concentration, and looking a lot at the urine. Okay. All right. SIADH. So excessive secretion of ADH. So there's no osmotic stimulus for this. Like we talked about, the osmoreceptors stimulate ADH to be released when we need to retain more water. In this case, there is absolutely no stimulus. It is inappropriate release of ADH, right? Inappropriate. So just remember that over and over again. It's inappropriate release, and we'll go over the different etiologies that cause this. But it's inappropriate. So meaning that the plasma levels at the beginning were normal, okay? It wasn't hyperosmolality that triggered ADH release. It just did it inappropriately on its own. It should not be secreted, okay? It should not be at the party, but it is. Here's a table from Current that talks about all the common causes, there's a lot, of inappropriate ADH secretion. The ones I highlighted in yellow we'll talk about in a second. So, CNS disorders. So, the specifics on why a hemorrhage or an infection will cause ADH to be released isn't like fully understand. Just how I simplify it is if there's something going on in the brain, for whatever reason, ADH could be inappropriate. It could trigger SIADH, inappropriate ADH release. Same with pulmonary disease. We have no idea why someone who gets pneumonia or some maybe fungal pneumonia. You guys know that from infectious disease probably better than me. But like a upper respiratory or lower respiratory condition can cause SIADH. Get no stimulus, which is doing it on its own. Malignancies are really guilty of causing excess ADH secretion, specifically small cell lung cancer. 80%. It accounts for 80%, which is a big deal. Obviously, there's these other cancers that can be culprits, but really all I want you to care about is 80% one, right? Now, if you are in clinic and you have a patient who comes in for a wellness and you do a urine and you notice they have really concentrated urine, or maybe they come in complaining like, I'm not peeing that much, my urine's dark, and you do a lab workup and it's suspicious for SIADH, and you ask, do you have a history of smoking, or are you a current smoker? A lot of times this will be someone who smoked for, I don't know, 50 years, 45 years, and recently stopped. You need to do a chest, okay? Because that's tobacco history plus SIADH. You want to make sure they don't have lung cancer. Okay? That's just like a clinical pearl or tip for you guys. But again, don't memorize all the cancers, just lung cancer, SIADH. Medications. Let's talk through some of these. So antidepressants can cause excess ADH, specifically in your elderly. Cancer meds, convulsant meds can cause it. Some psych meds do. What's MDMA? Ecstasy, right? So how does ecstasy work? Obviously, people don't usually come in uniform saying they're taking MDMA, right? But active duty population, we still have to ask about illicit drug use, especially if they come presenting like this in the ER. But what does ecstasy or MDMA do? Yeah, for a little bit. Yeah. So it affects essentially they'll have dry mouth and they're thirsty, right? So we're gonna, it obviously causes increased ADH. So we're retaining ADH, but then we're drinking a lot, and so it really correlates to dehydration, and people can it's like a water or fluid overload to the system, so not great. Opioids are a common cause of SIADH, and some antibiotics. So looking at that med list, I do not expect you to know all of this because this is not pharmacology. But what I would do is if I have a patient with SIADH, maybe they also are on an antidepressant. They're 65-year-old on an antidepressant. Or they're also on opiates. Does that make sense? So just know that meds are a huge factor. When you have someone with SIADH and you're trying to figure out what's going on, it could be medication. Okay? Is that fair? Like that, okay. And then other causes, post-op. Post-op is really common. And they'll have, I typically go through a phase of diabetes insipidus, and then there'll be an SIADH. So post-op, just like the respiratory thing, is a pretty common cause, as well as HIV, pain, stress. And obviously post-op is the bigger out of those. All right, so we know SIADH is inappropriate release of ADH. So excess ADH. Now how do they present? Any questions before we go? We talked about etiologies. All right, we'll go into presentation. So when we think someone has SIADH, we have to think is this acute or chronic. And this is super important when it comes to treatment later. A lot of times in medicine, people will say acute, but not give specific parameters. But for SIADH, it's very specific. So less than 48 hours, it's acute. Anything over 48 hours is chronic. Okay. Most of the time, you will see chronic. I've never seen acute SIADH, but it's definitely what do I say when I say sick, not sick? What does that mean to you? Patient comes in and your preceptor's like, sick, not sick. Yeah, like acuity, right? No acute distress. The sick, when I say sick, they're in distress. Something on the back of your hair on the back of your neck stands up. Something is like, I don't know what's going on, but this patient's sick, right? So that's going to be your acute, typically. But again, the time frame matters. So acute, they have acute brain swelling because of the rise in intracranial pressure, right? So excess ADH, so fluid overload, a lot of water retention, headache, loss of consciousness, they're disoriented. If they're nauseous, they might be throwing up, which obviously this is worse in this scenario, right? Marked confusion, and then these people can die. Not as common, but understanding the parameters, right? It's very sick, less than 48 hours. Versus chronic, they're often asymptomatic. So a lot of times this is that person that you get your annual CMP and their sodium is a little bit low. And so it's found incidentally, that's what that means. Through a further review of systems or talking to a patient, you might find out that they have some issues with their gait. Or kind of fogginess. It says cognitive impairment, but a lot of people will be like, yeah, I'm kind of in a fog. Or have issues concentrating. That can also cue you into this chronic SIADH. And then of course, if people have known SIADH, they're more vulnerable to hyponatremia exacerbations, right? So they're already living in this state of excess ADH. So they're just more susceptible than the general population to their sodium dropping. Okay, so where you have someone whose urine's a little bit off, or maybe they complain of dark urine, and we're going to work them up. They had a recent lung infection, or they had known lung cancer, and they're on opiates, something like that, and we're thinking SIADH. We need to ask them about their pee, right? With SIADH, is their urine output going to be increased or decreased?
Decreased.
Yep. And labs. What labs do I want? Urine. Okay, urinalysis. I like it. What else? CMP. What will the CMP tell me? Sodium. Yeah, all the electrolytes, especially the sodium, right? Awesome, good job. There's a few other things that you guys will do a urine osmolality, so that's going to be the concentration specifically of sodium. A UA doesn't do that, so it's an additional test. And then that's serum osmolality. Remember that math problem that included sodium, glucose? We're going to specifically check that. And then I have this a few times, but just remember the signs and symptoms of SIADH. You just remember that that low sodium level that they have is due to excess water, not a true hyponatremia or deficiency. Okay? I have that in here a lot because that's important when we look at treatment. So, low serum sodium, hyponatremia, does that make sense? Why? Why? Right? What's ADH does what to the serum water?
Lots of water.
Yeah, so it dilutes it. Yeah, so we dilute. So hyponatremia, SIADH, they go together, right? There is a range of hyponatremia in the box there. People with SIADH, they can have like mild, maybe have like a sodium of 131 and look awful. Or they could have a sodium of 126 which is fine. So it doesn't, this classification doesn't equate to clinical presentation. I absolutely do not expect you to memorize this. But remember there's just like, I guess, ranges of hyponatremia. Okay. But SIADH, they retaining water, they will have low sodium. Serum osmolality will be low, right? Because the concentration is diluted. And then we have this very concentrated urine. High urine osmolality, right? So we're looking at the solutes in the urine. It's high, concentrated. Urine sodium is high. Urine specific gravity. So if they take that cup of urine and I look through it, it's going to be really dark. I'm not going to be able to see through it, right? Really dark colored urine. And then there is a lab test to actually check ADH, but we don't measure that directly in these patients because remember it's an inappropriate release, so instead we rely on the urine osmolality. That makes it concentrated urine and then low serum osmolality, low sodium. And this is just, I'm a chart person, sometimes it's just like all of it on one page, so I've added this. This is what your labs are going to look like. Again, that concentrated urine. Okay. Again, you lean on what normally happens with and how ADH works. All of these labs should hopefully make sense. Okay, any questions on this? Okay, it's the first exposure to endo labs. They get better. They do. All right, so we'll pause here for till 20 after. And then this slide, the next slide is just like a current thing. So we're talking about SIADH, the labs. You have a nice little table. It makes sense because you know the pathophysiology of what ADH does, even in this inappropriately triggered scenario. Okay, again, treatment. This is not somebody who is truly hyponatremic, right? They're hyponatremic because of excess water. So with anything like this, we want to obviously focus on that treating the underlying cause. So let's go back to those etiologies. Maybe it's medication, right? Anticonvulsant medicine, opioids. If it's a malignancy causing it, 80% of the malignancies causing SIADH is what? Small cell lung cancer, right? Maybe they recently had a pneumonia, or they recently had a hip surgery, or they had some kind of maybe a TBI or a hemorrhage, a stroke, something interrupting the CNS. And we did the labs, and we're everything's pointing to SIADH. Talked about underlying cause. Now, just like when we broke it up to acuity at the beginning with the clinical presentation, we're going to rely on that plus the severity of symptoms when it goes to treatment. Okay. So back to the acute versus chronic and the severity. So we'll get acute out of the way. It's less likely, right? Chronic is much more common, thankfully. And again, acute, it's these guys are sick, right? And they have such low sodium, they're really symptomatic. You say we're loss of consciousness, confused, we're worried about these people, and so we want to give them what they're missing, and we treat with 3% hypertonic saline, okay? And with these, only time we'll treat with the sodium replacement fast is in this acute phase, okay? We treat it at the rate at which it fell, so much quicker than usual. That is not a normal thing, we rarely do that. So only time we will do that in this. Okay. Obviously, there's some calculations of how much we give them, how it makes sense to monitor them, right? We're going to frequently monitor these people. Are we overdoing it? Is what we're treating them with, is it working? Furosemide is a diuretic that can help with fluid overload if we need to. But again, this is an acute, severely presenting patient. We're going to give them hypertonic saline and monitor them. People who are in the acute phase can technically be mild to moderate, but you really only catch those in the inpatient setting, so that's not necessary. So no, okay. Any questions on the acute phase and the treatment? Hypertonic saline at the rate at which it fell, which is pretty fast. And then for the chronic, which is again the most common, there's two scenarios that we're going to dive into. And one is that asymptomatic or mildly symptom patient versus the chronic patient who has severe neurologic symptoms. So we let the neurologic symptoms kind of point us in the direction of how we're going to treat it. Okay. So let's talk about first the chronic over 48 hours. Again, this is that mildly asymptomatic patient that maybe is found incidentally through a history or through wellness labs, and they feel fine overall. So then we're going to, of course, figure out what's the cause. So they just had surgery and it's temporary, or is it just a lung infection and it's temporary? Let's focus on that. But the treatment for this is fluid restriction. Remember, they're in this fluid overload causing hyponatremia. So we can simply restrict their fluids to 1 to 1.5 liters per day. Is that a lot of water? Oh, every time I read that, my mouth gets dry, I want to take a drink of water. But this would work, especially if it's just maybe a temporary time frame where you think they're dealing with SIADH. And it's always awesome when you can give someone a treatment that doesn't require a medication, right? And comes with side effects and interactions and things like that. But it should make sense that this has poor compliance because people who like to drink water, most of us usually. And typically it's only considered for people who have a mild sodium deficiency. Okay. There's also medications that we can give these patients too, and we'll talk about those. On the other hand, if we have a patient with SIADH, but they are presenting with severe neurologic symptoms, so seizure, confusion, then we're going to want to go and give them the hypertonic saline, okay? But slowly. And this is normally how, if someone's hyponatremic, how we replace it. We replace it slowly. And the reason is we want to prevent something called locked-in syndrome. I think I talked about it back here. Osmotic demyelination syndrome. Have you guys heard of that? Maybe in farm. So what happens is if you replace this sodium too quickly in someone who's hyponatremic, regardless of the cause, it can cause damage to the myelin, and then they get paralysis. If it gets really bad, they're alert in here but can't move. And it's not always, it occurs later, but then it's not always curable. So, but for whatever reasons, the studies show in an acute setting, locked-in syndrome is much less likely. So that's the only exception. Okay. All right. So we're going to go slow. And then, of course, we're going to monitor. We can use our furosemide. And we'll talk about what vasopressin receptor agonists are in just a minute. Okay? Treatment making sense? Yeah.
We're working on the hospital situation. We typically have those minutes, 3 minutes, call the pharmacy.
I would call, especially if it's hospital, they'll the pharmacy, because they're making their bags actually, at least when I was in school, they would make the bags at the pharmacy on the night shift. But yeah, you would call. This isn't super common, but they can get it really for you. Because what do we usually have? What's our go-to? Normal saline, lactate removed. Okay, so when we alluded to medication for both someone with neurologic symptoms and then the more common where they don't have any symptoms, there's medication. So you have your vasopressin receptor antagonist, or Vactins. You guys learned about that in pharma a long time ago. I intentionally don't have the drug names, but what they do is they'll act on the V2 and V1 receptors, and they inhibit ADH. So there's Contadaptin, which is used, but it's non-selective. So it inhibits that V1 and V2. And there's Tolidaptin that is specific to the V2 receptors. And I'm not prescribing Tolidaptin. You can only use it for like 30 days. There's a lot of liver risk and all that sort of stuff. So if I'm thinking about medication, I'm gonna go to my friend, right? A nephrologist, endocrinologist. Nephrologist is probably easier to reach, but just know that they exist. Loop diuretics, specifically for Soramide or Lasix, but then we need to monitor our electrolytes. So democloprazine is a tetracycline. It's an antibiotic that it actually diminishes the effects of ADH. So you have excess ADH, and it works in the renal tubule, which is proximal to the collecting duct. So it can actually diminish the release of ADH. But if we give them something to fix ADH, what could we cause? Or SIADH, what could we cause? DI, right? We can cause another problem. And then the last one's FYI, Current just added it, but SGLT2 inhibitors could potentially be used. But again, usually the blood glucose has to be like at 180 for it to dump out of the urine, so don't worry about that one, just FYI. When to refer? So we're referring to nephrology, endocrinology, and if I don't have like a true underlying cause, I'm gonna refer. I'm gonna maybe work them up if I'm thinking malignancy, I'm gonna do a CT scan, maybe follow up with them if I think it's like a lung infection triggered or a post-op trigger. But if it's chronic and not getting better and I can't figure out the cause and fix it, then you wanna refer. And then obviously there's protocols in the ED for the monitoring of patients when you get on the hypertonic stimulation. Okay. Any questions at all on SIH? Diabetes insipidus, which is the exact opposite. Too little ADH. So we cannot concentrate urine, so we have a large amount of really dilute urine. So if they pee in that urine cup, you can see right through it, right? It's super, super clear and dilute. And these patients come in complaining of polyuria and polydipsia. Right here it says hypernatremia. I'll talk about this all the time, or a few more times, but hypernatremia is a problem if they can't maintain their own fluid intake. So I'll describe why that is in the next slide. You guys heard about diabetes insipidus? So what's insipidus related? It just means tasteless, where diabetes mellitus is sugary. They used to taste urine back in the day. I guess equivalent to academic counselor was a PA when they used to So there are 4 types of diabetes insipidus. Central, nephrogenic. Primary is where you do it. The patient does it themselves. So they may be hazing, or they have like a mental health disorder where they're obsessed about water. And then gestational, so things change when you're pregnant, right? We're only going to focus on the first 2, central and nephrogenic. And thankfully, the name tells you what's going on. So if I say central, diabetes insipidus, where's the problem? And that's really centrally, right? I'm looking at the pituitary, I'm looking at the head. Is there some kind of issue? Is there some kind of trauma that's disrupting the synthesis of ADH, either the synthesis or the secretion, right? The release. Is there some genetic factor? And then nephrogenic, where is that pointing? To the kidneys, right? And so this is where that resistant hypofunction comes from. Because you have plenty of ADH in the system. The osmoreceptors in the brain work. The posterior pituitary is doing what it's supposed to. It's releasing ADH, and it goes into the bloodstream, but it can't be used in the collecting ducts, right? So it's resistant. And typically it's due to a genetic issue or some kind of kidney disease that they have. But the most common other cause is lithium. People who are on lithium get this often. Lithium is kind of common when I first was in school, but we have better meds. But it's still a viable treatment option out there, so you might see it. And then obviously, we learned about this tetracycline here, right? How that can cause, so yeah. This should all make sense. Etiologies, right? Some kind of trauma, inflammation, some disruption in the brain versus nephrogenic. Any questions so far? Sounds pretty straightforward. Alright, so signs and symptoms. They are peeing a lot. And if I'm peeing a lot and drinking a lot, would I come in and see my PA or my doctor? Maybe not, right? Because they think like the reason I'm peeing a lot is because I'm so thirsty. And so it kind of makes sense. But when they usually start coming into you is when the pee and the urination is keeping them up at night. So if you're like me and you like your sleep, which you guys probably don't get to enjoy sleep right now, one day, you'll get to sleep again. But if you're waking up 4 or 5 times a night to pee, that'll probably bring you in. Or you're having accidents because you can't get to the bathroom in time, things like that. But again, people might ignore this for a while. And it can make sense why. Now, the cool part about this is so you have not enough ADH, so you're peeing out all this water. The thirst center in the brain is close to those osmoreceptors. And the thirst center is triggered, and so it makes you drink. So that's what's making them drink. And so you're technically, even though I'm peeing out all this excess water, I'm hydrating more. So it's kind of your body's way to maintain as close to homeostasis as they can. So in a way, that extra hydration is treating the problem temporarily. But if they're unaware of thirst, or they have no access to water, or maybe say they get an acute gastroenteritis and confused and they're throwing up and they're nauseous, they can't drink, then it becomes a problem and you're really concerned for hypernatremia, right? Because all the water going out, so they have that vascular collapse, hypotension, dehydration. Okay, does that make sense? Okay, same workup with the patient has a history of urine production and DI. Is their urine increased or decreased? Yeah, exactly. And we would care about the thirst in this, right? Because if they're not able to drink water or the thirst receptors aren't intact, then we get worried about hyper. Okay, so what labs do we want? We know a little bit more about labs. What do we want? CMP for which electrolyte? Sodium. Yeah, what else? Urine osmolality, yes. Yeah, a urinalysis. What can the urinalysis help me? Besides just like the specific gravity, which is that concentration, how does the urine also help? ADH is the lab, yeah. What does the urinalysis tell me? When I order UA, why would I order UA? Glucose, yes. And then infection, leukoesterites, that sort of thing, but glucose. Why? Because what other condition presents with polyuria and polydipsia? Diabetes, yay, yes. And then we have ADH. So ADH is the lab we talked about. We can't use this SIADH, but we can use it when, in this case, we'll talk more about ADH. And then serum osmolality, that probably would be a good one. Here's your table. The only thing we didn't talk about is the 24-hour urine. Who wants to tell their patient, here's a jug, you're going to go to the lab, you need a big jug, and I need you to pee and collect your urine for a full 24 hours. That's critical to making the diagnosis because they have to pee over 3 liters in 24 hours. If they don't, if they're peeing at 2.5 or 2 liters, it's not diabetes insipidus. So you have to do this annoying 24-hour urine test for the volume. And we actually get to talk about 24-hour urine tests a lot in endo. This is just your first one. This one just makes the most common sense, I think. But you have to have excess urine that's dilute. So you use all of this other things. Questions on that? Outside of the table is a vasopressin challenge test that helps differentiate if it's central or nephrogenic. But remember, the history and physical exam can also help you. So we'll go dive into these a little bit deeper. So again, 24-hour urine collected. It's elevated. If someone's inpatient, they don't do a 24-hour urine. What do? They monitor what? Urine output, right? And so that's a little bit differently. But so if I have an inpatient scenario on the test, I'll tell you that it's elevated. But you need a 24-hour urine, and it has to be elevated. They don't have to restrict their fluids or anything like that. Urine osmolality is low. Does that make sense? Yeah. Why?
Because there's a lot of fluid being
Yeah,
pushed in
it's
there.
diluted, right? Just like that specific gravity is going to be low. Negative glucosuria. Plasma osmolality in this one is elevated in both nephrogenic and it could be in nephrogenic or central elevated, right? Because all of our water is exiting the body. Sodium will vary. It varies on how much they're drinking, all of that stuff. So I won't quiz you on sodium specific on the test just because it varies. It could be normal or it could be hypernatremia. Okay, does that make sense? Just leaning back to that thirst center. Now, vasopressin was talked about here, so we can actually do a blood or plasma vasopressin test to tell us. So in here it says it's usually low in central. So central, where's the problem? If I have central DI, where's the problem? The brain, right? So that means the brain's not producing ADH, which makes sense, right? ADH would be low. If nephrogenic, the problem is in the kidneys, and so I have plenty of ADH, which is why it's either normal or high in that case. Okay, so you can use that ADH lab or vasopressin lab, to help point, is this central, is this nephrogenic? But it's endo, and we have a lot of they're like either called dynamic testing or confirmatory tests, and this one is the vasopressin challenge test. I do like at least that the name has to do with vasopressin, so it's somewhat easy to remember. But this is not something that you will do in your clinic, right? So the patient, they're monitored and admitted in the hospital. And they're going to monitor all of their urine and their labs for like 4 to 12 hours. And then they're going to give them vasopressin. And the prescription, it's called desmopressin acetate. They're going to give them ADH and see what happens. So if I have, let's see, I have nephrogenic DI, and they do this test. They give me desmopressin. What do you think is going to happen? Is there going to be a change in my urine output?
Nothing.
No, nothing's going to change because it's resistant. It's a resistant issue. Versus if it's central, we will see a change, right? We finally have ADH, what my body's been missing because of my, I don't know, I had a pituitary surgery and it screwed things up. Okay, does that make sense? If you ever get stuck, you can lean back to like what normal looks like, and the truth. There's a lovely little table of all of the labs. And what to expect. A little summary. Imaging. What imaging do you think we could order for a patient who might have diabetes insipidus? Yeah. Yeah, MRI. We could look at the brain. So, pituitary. You don't have to. This won't be on the test. This slide won't. But I think it's just important to know. So it's called bright spot signals that indicate the posterior pituitary is small. Okay, so remember it's small. If it's undetectable or small, then that could mean it's a central problem. If it's normal, it can point to a nephrogenic problem. Okay. But I will not. This RADS, I won't let you go. Differential. Cool. All right, treatment. So we have someone with central diabetes insipidus, and maybe it's really mild, and they don't mind drinking water. You could just give them adequate fluid intake. But you'd have to counsel them, like, hey, the treatment for this, we're going to figure out what the cause is. Maybe it's CNS, or maybe we're waiting until they get into endocrinology to do that vasopressin test. For now, while you're waiting, you can just give that, make sure they get enough water, right? Because it's kind of how the body is managing its own homeostasis. But if it's waking them up at night and they are frustrated by that, we can give them desmopressin. And this is obviously, we're giving what the body is making, right? Central DI. Will this work for nephrogenic? No, it won't. You don't need to know their doses, but typically you can do this, it says twice a day, but I would start them at night. You can do a nasal or oral medicine, and you want to do the lowest dose possible. And I would start them at night first, see how they do, and then you can increase to twice a day. Monitor your electrolytes, obviously, because whenever we're messing with electrolytes, we can go hypo or hyper very easily. Okay? So if it's inhibiting function, or you're concerned about the patient's ability to maintain adequate fluid intake, give them desmopressin. Make sense? All right. Nephrogenics is a little bit different. Obviously, we might look at switching lithium, obviously referring them for sure, calling our nephrology friends for help. There are medications that we can use to help while you're waiting for them to get into nephrology. So with these people, they're peeing a lot, right? But I'm going to give them a diuretic. I say diuretics just going to do more. The trick with thiazides is that they work higher up. So since they work proximal to the collecting ducts, it helps improve it. Okay. Same with indomethacin. Has to do with prostaglandins. None of this you have to memorize, but again, there's medications that you can give them before they see the nephrologist. People usually do pretty well, specifically central. If they had some permanent damage, they do fine on the medication and the fluid intake, and then we can get them good sleep, right? With the medicine. Okay, so just like a usual thing, I added this, just another summary of all of the labs and the comparison. Don't memorize this, like just lean back on what we talked about, the normal pathophysiology, and that'll be better. All right, we're going to do a clinical correlation, and then we'll wrap it up. This one, interaction, PL, vocal. You don't have to look at your screen. At the end, I will post all the clinical, what I call them clinical correlations, and the check on learnings at the end, so they're in one big PowerPoint. Again, when you're in phase 2 and you're in clinic and you get asked by your preceptor a question, you're either going to get lucky and you got it, or you're going to get lucky and you don't know the answer, but you look like the answer, or you have no idea, and that's okay. So this is kind of like a way to be comfortable being uncomfortable, okay? And it'll get worse when we get to the lab. Each one of you get an opportunity to do it individually, answer questions. I hated that. I'm sorry, but you gotta get used to it. Best way to do it is practice. All right, so we have Nathan Light. He is a 55-year-old male with a history of recent radiation treatment for a metastatic small cell lung cancer. And he comes in, he's not feeling great. He has some nausea. What do you think? Just from yes, we've only learned 2 things, so we kind of I like this. We just got here. Have to test this tomorrow. All right. So he states he's gained 5 pounds over the past 3 days, but he denies any edema. He admits that his urine has appeared darker lately. He's on morphine and prednisone, and he has some supplemental oxygen. No change to your diagnosis, or still ADHD? No. All right, what we're gonna do? We've got a good history. We're gonna get a physical exam. And how are his vitals? Concerned? Might be okay, right? Like so far I'm okay with that. We can always look at his last blood pressures and see if that's normal, but it's okay. His lung exam's cleared of auscultation, regulating rhythm, no murmur, regular gallops, no edema. We get your initial labs, which is a urinalysis. Specific gravity, is that high or low? High, yeah. So, not the diagnosis, but what is the list of this gentleman's problems? Nausea, yeah, when he came in, he doesn't feel good, he's nauseous. What else? Nice. He has lung cancer. Yeah, he has dark urine, and we confirmed that it's concentrated. He's gained some weight. Yeah, so here's, I think we got it all. Good job. So what is the next step for this guy? We have a UA. Yes, more labs. Almost 90% of the time when I say what is next in endo, more labs. More and more labs. So we get a CMP and sodium 130. So it's low. Creatinine is fine. Plasma osmolality is low. Urine osmolality is high. Any thoughts? Does that make sense, right? So plasma osmolality is the concentration of the blood. Urine osmolality is the concentration of the urine. One's high, one's low. These hyponatremia. What's our diagnosis? SIAH. Good job. Secondary to what? What do you think? Cancer. What else? Radiation. Yes. What else? Medication, the morphine. Look at you guys. You can see all of these things. So what do? So he's like mild. Does he have neurologic symptoms? No, right? Yeah. So we can restrict his water, educate him, making sure like look at all of his meds. We can consider some medication too. But right now, we'll do some fluid restriction and give him some nice precautions of when to follow up. First patient, you guys treated well, but he's back. And his wife states that he's been vomiting, he's disoriented to time and place, and that is a really bad headache, severe headache. His sodium is 123, and it was 130. Normal is 135, 140. Okay. Yeah. What do you think? Yeah. And we kind of want to know, like, is there any neurologic symptoms? Obviously, what is scary? Yes. Disoriented, I don't like that. And yeah, and he's only 55, right? I think so. But still, that's scary. How do we treat this? So we have SIAH with worsening hyponatremia. He's starting to not look so great. He has neurologic symptoms. How do we treat him? Yes, hypertonic saline, slow or fast? Slow, which is normal. Slow is, what is it? Slow is nice and saying. Yeah, thank you. Yeah. Yep. So yeah, slow. Okay, so we give IV hypertonic saline 3%, not too fast. We can consider for furosemide for the fluid overload, consider our Vactins, things like that. God, you took care of this guy. You happy with him? Me too. Good job. All right. Last patient of the day. We have a 40-year-old female named Tinkerbell, and she is 18 hours status post a transsphenoidal resection. So what that is, we're talking about, it's just a removal of pituitary adenoma. Okay? And, I just read that. For pituitary adenoma. She complains of insomnia due to thirst and nocturia. She also reports urinating more than she has ever before. What are your initial thoughts?
Central DI?
Yeah, SIAH-DI. We're thinking central, I think, too, based on the history we got. We do a physical exam. Vitals are, what do you think? Heart rate's a little tacky.
Okay.
Again, that could be for normal blood pressure. Unremarkable physical exam. Slightly tender bladder. What do you guys want to do? Labs. Which labs? Urinalysis, CMP. 24-hour urine? Yes, that's the right answer, but then if we're in an inpatient scenario, we'll do the urine output. The nurse, they'll run a urine output. What else? Osmolality, urine and serum, right? Yes. And there's one more blood test that we can add when ADH is low. Vasopressin, yes. So, you get it all? 100%. You got it. We just take the test like this. Okay. I mean, I wanted to have class outside, but you hard ones. All right, so what do we see? So serum sodium, it's on the high side of normal. Calcium, I haven't talked to you about potassium, looks good, but urine specific gravity, is that high or low?
Low.
Urine output can tell you it's high.
Uh-huh.
So that equates to your 24-hour urine. And the urine osmolality, that urine concentration is low, which makes sense why. Because what color is this person's urine? Okay, problem list. Ugh. What is this guy? Or girl, sorry, Tinkerbell. What does she have?
Can't sleep.
She can't sleep. Why can't she sleep? She's she's thirsty. Her labs show what? Yeah, super dilute excess urine. Oh, it's insomnia, right? Nah, she wants to rest. What are we treating? Or what's the diagnosis? UTI. Okay, so central nephrogenic, 50 shot. Central, right. So you think it's central, you could do an MRI, or you could do, you're in the hospital, you could do a dynamic or confirmation test. What is it? Vasopressin challenge test. Perfect. So, the vasopressin lab is healthy, right? Because that can help you too. So do we expect a response when we give this patient desmopressin? We give them, yeah, exactly. Good job. Thirst decreases. Everything gets back to homeostasis. So we know this. What's our plan? So sorry for the recording. Central diabetes insipidus, secondary pituitary surgery. What do we do? Yes, prescribe desmopressin. And what? Should they drink a lot or not drink a lot? They should maintain a good hydration. But you don't need to restrict their because that just helps them. They don't. That's not the only treatment. Adequate hydration. Replace what damage. All right. Good job.